Good morning or good afternoon to all of you attending this meeting. Wonderful that you're here. Let me introduce myself first. I am Margot Kooijmans. I am director of the Philips Foundation, and I want to tell you a bit more about the background of the Philips Foundation, which is connected, of course, to Philips. That used to be a lighting company and domestic appliances, meanwhile, in its 128 years of its, or 130, I must say, of its existence, it has become a leader in healthcare technology. Meaning that also the Philips Foundation, that was established in 2014, has developed to an institution that wants to promote and to provide quality healthcare to disadvantaged communities. That's the mission, and in everything we do, we want to provide access to healthcare to people that have no access to healthcare technology mainly. In doing so, we not only use money, but we also, and that's the biggest asset we have, use the capacities and the capabilities of Philips as a technology company, healthcare technology, but also the innovative skills of the employees, and the power we can bring together with other organizations we collaborate with. We have grown from donations mainly towards wanting to understand models to really not only provide access to healthcare, but also to maintain those the access, and also to create sustainable models. So what we have learned is with donations, you can start up something, but we see often also it ends when we pull back or when the money stops. And that's something we want to avoid. Also in providing equipment or solutions, we don't do this for the reason of ending it within a year or when staff is lacking, or situations where drug supply or referral is not available. So we always look at the full ecosystem, and we try to really understand what is lacking or what is helping and what is a potential solution. That's why we also wanted to disseminate our learnings and to discuss the learnings we have found with the partners in this webinar. We really want to do that much more. So this is one in a series that we want to organize, bringing together the wonderful knowledge and insights we have found and our partners have found in the projects we supported. So I'm very proud that we have found Dr. Eunice Riarango Mugo to moderate this webinar. She is the Associate Professor and the Dean of the Aga Khan University School of Nursing and Midwifery, and the Chairperson of the Nursing Council of Kenya. She graduated from University of East Africa, Baraton, in Kenya, with a Bachelor of Science in Nursing. She later pursued her Master's in Advanced Nursing Practice from the University of Nottingham in the United Kingdom, and in 2016 she completed her PhD in nursing studies from the same university. As we will see in this webinar, strengthening the role of nurses in task-sharing models is an important element in the models that we have been exploring. I wish you a wonderful meeting, and I couldn't find anyone better to moderate this session than Dr. Eunice. Over to you.
Hello, thank you so much, Margot, for that really kind introduction. Hello, everybody from across different geographies. Welcome to this webinar session. It is really such a pleasure for us to host you today, and thank you so much for making the time. As alluded to by Margot, we cannot really, in this part of the world, not talk about maternal and neonatal deaths. This remain a key priority issue for all of us in developing world, but also globally. We know without a doubt that the mortality for maternal mortality ratio is 20 times higher in developing countries than in developed worlds. Most of these cases really happen in the rural areas, in people or among people who are really vulnerable, but also among those who have difficulties accessing care that might be available and confined within certain cities or certain health facilities. So really what we are looking at here is what are the potential solutions to prevent or to really diagnose some of the challenges that mothers might be having prior, during, and after childbirth, because saving women and saving children and newborn babies' lives should be something that is a priority for all of us. So to help us address these questions and to help us see how we can address this, and going back to the link between technology as a solution to ensuring that there's access to healthcare, particularly for mothers, I have a really panel of distinguished guests joining us today, and we'll have the webinar happen in 3 key elements. The first one will be the keynote speakers, and we'll have 4 of them: Professor Marlene Timmerman, Priscilla, Professor Kristen, and Dr. Alina. This will then be followed by a panel discussion with our key distinguished panelists, Dr. Bashir, Angela, Dr. Matthias, and Mahal. We will then have a question and answer session. This will provide you, our listeners today, with an opportunity to really interact with the panelists, during which you can ask your questions. I'll urge you to use the chat available in your webinar today to really ask your questions throughout the sessions as we go along. We will then have the closing remarks that will be done by myself and Mahal. To kick us off today, I think we need to reflect about how can we then use technology to be able to address some of the challenges that we know are arising. Looking at the title of our webinar today, which is Models for Maternal Ultrasound Screening in Limited Resource Setting, one of the key elements, and that comes to me as a nurse and something that I'm really passionate about, is how do we make use of nurses and midwives that are available in the healthcare system to be able to access or increase access to certain services that we have. So I'll now focus on going back to our first keynote speaker, and that's Professor Marlene Timmerman. I'll give a brief introduction of who Marlene Timmerman is. Marlene is a professor in the Department of Obstetrics and Gynecology and Director of Women's Health, Faculty of Health Sciences at the Aga Khan University. Marlene comes to us with a wide range of experience and expertise in women, children, adolescent health. She has a strong track record working with governments, multinationals, academia, professional bodies, among other agencies, both private and non-governmental. She has been the chair of OBGYN at the Aga Khan University Hospital and also the director of Center of Excellence for Women and Child at the same facility. Prior to that appointment, she was the director of Department of Reproductive Health and Research at the World Health Organization. She has also been an elected senator for the Belgian Parliament. With over 700 publications and books in the area of women's health, I am sure you agree with me that she's well fit to speak about this subject matter. I will now welcome Marlene into the session to get through to her presentation. Over to you, Professor Marlene Timmerman.
Thank you so much, Eunice, for your kind words and for this introduction. And thank you, Margot and colleagues from the Philips Foundation and Philips to organize this webinar. May I ask the first slide, please? My presentation is on a project that we are running here in Kenya, in Kilifi, called Mimba Yangu, and that is the Swahili for my pregnancy. Before maybe I go through the details of that particular project, I would like to to say a few words. I'm an obstetrician gynecologist. I'm trained in the Netherlands and in Belgium. That's my home country. And I've been in obstetrics and in ultrasound for over 30 years. And the ones who were teaching me the basic obstetrics were the midwives in the Netherlands who were actually mandated to do the ultrasound, the basic ultrasound, and then, of course, if there is something, to refer to a higher level. So my basic training, before then I went to the higher levels to become a trained gynecologist and had my diplomas and fellowships in ultrasound, was actually done by midwives. So the question is not, can midwives do basic ultrasound? Of course, everyone who is trained in ultrasound and obstetrics can do it, be it a sonographer, a nurse, a midwife, everyone who has the basic knowledge, of course, in basic health science. So this is not what we are trying to address in our pregnancy, in our Mimba Yangu project, because we know that with good training, midwives and nurses are key healthcare providers who can, of course, play a very important role in providing ultrasound screening and diagnostics. The other point, before I go to the details, is that as far as I know, ultrasound in pregnancy, obstetrical ultrasound, is one of the few diagnostic tests in medicine that women and also their partners are really looking forward. In other settings, like in oncology or in medicine or in whatever, if you tell patients we have to do a test, they are rather scared and asking questions, and do we really need it? Whereas in obstetrics, it's kind of the women who are asking, at least in Europe and in most parts of the world, doctor, can I have another ultrasound, please? Because they like it very much. So this is an advantage. Now, as it was said in the introduction, we have some guidance, and my slide now to introduce the context is giving you a number of statistics that, as was said already by Eunice and by Margot, every day around the world, women are dying. We are still at a very high maternal mortality rate, despite all the efforts that have been done. And in the Millennium Development Goals, we really saw a serious improvement. The goal was actually to reduce maternal mortality by 75%. We didn't reach the goal, but we reached as a community a goal of 45% of reduction of maternal mortality, what never happened in history before. Having said that, in this part of the world, Kenya is not an exception. The rates are still too high. In 2014 KDHS, we had a rate of 362 women per 100,000 live births dying in pregnancy. And one has to say also, not only in delivery, also because of abortion. In a country like mine in Belgium, that is 7 per 100,000. So, and in a county like Kilifi, the rates are even higher. Stillbirth and neonatal mortality rates are also very high. So in Kenya, we have still, and the Ministry of Health has progressed a lot in the last years, thanks to a number of programs like free maternity care, Beyond Zero, Ministry of Health programs. Dr. Bashir will tell us a lot about it. Situation has improved, but is still a long way to go. So this project, Mimba Yangu, is focusing on 7 sub-counties in Kilifi that are Rabai, Kaloleni, Ganze, and some additional 2 high workload facilities in Kilifi South, with an ambition to reach 200,000 lives in those 3 sub-counties, 200,000 women. Can I have the next slide? Now, what is the global context? As Eunice was saying, I used to work as director at WHO in Geneva in the department that develops the guidelines for pregnancy, delivery, women's health. And we started developing a guideline that has been published a couple of years ago, saying that actually every woman in the world, every pregnant woman, should have access to ultrasound and should have at least one ultrasound before, as early as possible in pregnancy, but before 24 weeks gestation, to estimate gestational age, to not estimate, to measure actually, to improve detection of fetal abnormalities, multiple pregnancies, and to have a better outcome of pregnancy in general. In addition, that is the WHO recommendation, there is also a need, of course, for improved communication between pregnant women, the community healthcare workers, volunteers, first-line healthcare providers. Now, next slide. Making a guideline from WHO requires a lot of time. It's evidence-based. All regions in the world, experts are involved. So it is really a very strong guideline. But it is easy to make a guideline from Geneva. But implementing this and having this done in a country is somehow a little bit more difficult. So the Mimbayango project, what is the aim of the project is, number one, can we really implement in the public health facilities a system where there is something with the presentations, I think. Can you still hear me? Yeah. So what the idea is actually to study feasibility in implementing this project in a real life situation. To implement this WHO recommendations of having an ultrasound for everyone. To strengthen quality of service provision. Increase, because we are hoping that by introducing ultrasound, that women might come earlier, as they do now, for their first antenatal visit, and maybe that because there is some service to offer, that they will also maybe bring their husband, a partner, so that there will be more engagement from their family into the pregnancy and the follow-up on the pregnancy. These are the goals of the project. Next. So what are we doing to start with? So the questions are, is it really feasible? Is it affordable and sustainable? Because as we all know, we do a kind of a pilot, and in the world we suffer pilotitis. We do a lot of pilots. We are on the average happy with the implementation, but then the donor or the support group, the pilot project comes to an end and there is no leverage, no kind of implementation in the system. So the question is it feasible, affordable, and sustainable to introduce ultrasound in routine standard antenatal care in public health facilities? That's number one. The key question, and I don't think that our project Mimbayango will be able, it's not powered to address that question, but we will try. Key question is, does routine obstetric ultrasound increase quality of care leading to better maternal, fetal, and newborn health? Ideally, we should have a very large population where we can study the pregnancy outcome. Do we really have reduction of maternal morbidity, mortality? Do we have a reduction? Do we have a better outcome for the newborns? That, I think, we start doing that, but we will require a larger study to address that question. So we go by proxy indicators of quality of care. Offering this service, will it increase the number of ANC4+? Will it increase male involvement? Will it improve the early attendance of antenatal care? And thus improved communication at primary healthcare level contribute to an increased referral of pregnant women in general, pregnant women at risk, pregnant women with danger signs. And the last question is, what is the applicability, relevance, acceptance, and cost effectiveness and implications on health service planning and provision at the primary health care level in the Kenyan context? How also do women and their families react to something? Because in Kilifi, for example, we found that right now there is no routine antenatal ultrasound. So somebody who is referred for an ultrasound exam is because there is a problem. So the community is kind of linking doing ultrasound means there is a problem. And maybe they think that the ultrasound can even introduce complications. So we need to be very clear that there is a very good communication to the patients and to the community, and that we involve everyone. Next slide. So besides, and here you see the Lumify portable ultrasound, which is really great to use as in the basic setting. In addition, I'm not going to dwell too long on that because the conference here is on the webinar on ultrasound, but we also have another tool that is called MOM. And MOM stands for Mobile Obstetrical Monitoring. And it's a software solution that allows community healthcare workers to perform antenatal risk stratification. So, I mean, the slide is there. We can provide much more information, but I'm not going to deep dive into the MOM. Why do I bring it up? Next slide. Because the study we are doing is actually it's a control study, not randomized control study. It's a controlled study with 4 arms where we have an intervention where we'll do ultrasound. The second intervention is we do ultrasound plus we introduce the MOM in the level 1 with the community health workers. The third intervention, we introduce MOM only, because maybe by introducing MOM without ultrasound, maybe we also have an improvement of the quality of care, the referral level, risk stratification, etc. And then we have a number 4, where we do it at a control setting, so also health facilities, where we do provide care as usual. And the idea, of course, as you can see from my slide, is really to measure starting with a baseline, then with an end line, to really see what is the impact of the ultrasound, the MOM, and the combined on the quality of care. Next. Where are we now? Of course, we have to start with the baseline. We started with basic obstetric ultrasound training of all these health facilities. So 34 public health facilities are included. And we have trained nurses, midwife in basic obstetrical ultrasound. We did this in Mariakani Hospital. Thanks also not only trained by the team in Aga Khan University, but we work together very strongly with the public health sector team in Mariakani. And Dr. Angela, you can see him on the picture. He is one of the trainers. So we work with our faculty, our residents, and with the team in Mariakani. In Mariakani, why do we do the training here? Because in a past project that we did through Aga Khan University in Kilifi, we have managed to build an e-health center, not only one in Mariakani, but several ones. So that in COVID times, we were very happy to have this facility because we could give the theoretical training and ultrasound from even from Nairobi or from Mombasa. So we could train the students there, you see them there, and we could, and then of course the hands-on training with patients that's had to be done in the clinic. But a lot of the theoretical training, the course could be given remotely. We have now conducted our baseline assessment. It was a bit delayed, of course, because of COVID, strike, and other realities of the ground. And so right now we are ready to start the intervention. Next slide. And here, this is my last slide. Indeed, a big thank you to the team. Here you can see Sarah Kedengi and Melanie, who are introducing the mom to the community healthcare workers. Here you see the name of the teams in Philips Foundation, Philips, AKU, and in the public health sector in Mariakani. This is my last slide. Thank you very much. Over to Eunice now. Thank you.
Thank you so much, Professor Marlene, for that insightful presentation. Indeed, the key question is not whether this can be done. The question is, we know it can be done. Thank you for highlighting the role that, task shifting in terms of ultrasound among pregnant women can be done by midwives, but also looking at the actual benefit of this that is around the role of ultrasound in increasing access to healthcare, but also getting pregnant mothers into the health facilities early enough, but also ensuring that, we have other advantages such as increased partner engagement. You've also really highlighted the key issue of cultural acceptance and the issue of perceptions around ultrasound and the role they play in terms of prevention, not necessarily in terms of treatment. That has really, really been insightful for us. And it highlights the key element that when you look at access to healthcare, now we are really talking about universal health coverage and looking at sustainable development goal number 3. We really need to think about how do we ensure that we use nurses who, as statistics start to show, are likely to meet about 80% of the population that is seeking service from a healthcare provider. I will now move on to the next speaker. Allow me to give a brief introduction to Priscilla. We've already heard how this intervention can work. We've heard about the care element of this intervention. So what would be then the business case for it? How would we get the midwives and the nurses who are doing the ultrasound to actually charge for this service? I will now introduce Mrs. Priscilla Njungu, who is the project coordinator for maternal, newborn and child health at the AMREF International University. In her role, she leads the implementation of projects, and during that involves projects that positively impact on mothers and their children. She has coordinated leadership and management governance in midwifery services, and she has also managed a social entrepreneurship project in 2 Kenyan counties and is currently managing the obstetric ultrasound screening for midwives. She holds a Bachelor's of Science in Nursing and a Master's in Public Health. She's actually an alumni of the prestigious Women in Leadership program at the Strathmore Business School. As Priscilla starts to talk to us about her presentation, I want to remind all our invited participants, please use the chat platform to keep bringing in your questions, which will be addressed at the opportune times as we go along. Priscilla, over to you.
Thank you so much, Dr. Dirango. I am grateful to be here and glad to be here. I will start by a small sharing of what I am currently reading and has really impacted in the work that I do. I'm reading this book, Start With Why, by Simon Sinek. And as I reflect upon the work that I do with the organizations that I have worked with AMREF, every time we do something, we have to start with why we want to do something. And for AMREF, we have been in the belief that we want our communities to be healthy, because a healthy community translates to so much. It means economic growth, etc. For Philips Foundation, I believe that is why we found each other, because they have the heart of health in their core business, and that is why we are here. So I will share part of what we have been doing as AMREF in relation to ultrasound screening. We have, personally, I've been training midwives for over 5 years, implementing projects that impact on their capacity, and also the work that they do, because my greatest joy is to see a healthy, smiling mom holding a very healthy baby. That picture always rings to my mind in the work that I do. And that is what we do at AMREF. Our vision is always to ensure that we have healthier communities, not only within Kenya, but outside ourselves. Yannick, please go to the next slide. In the background, Prof. Marlene has actually expounded on the work that they did at WHO and why it is recommended that each woman is to get an ultrasound before 24 weeks of gestation. I will not repeat. In the Kenyan context, as we were doing our survey before we started this project, we got the data that we have less than 1,000 sonographers, yet our health facilities, private and public, go beyond or are next to about 10,000 health facilities. And as you know, because we have a shortage of healthcare providers, be it doctors, nurses, be it sonographers, that number of healthcare providers that we train cannot be enough for the health needs of our Kenyan population. We also did a bit of background and only found data showing that about 25% of pregnant women access obstetrical ultrasound, meaning that a huge percentage of about 65% do not access the ultrasound, and especially in low socioeconomic areas and also hard to reach areas. And after we sat down and looked at what we really need to do regarding ultrasound, because of the benefit of what an ultrasound can do, that is for the mother and for the child, or rather the fetus, then we decided to go ahead and start a pilot. I have had a comment where Prof. Marlene has said that most of the times we start up pilots and we become these organizations that keep doing pilots and never go ahead to scale those projects up. And I'm glad that this is one of those projects that we are committed to see it scale up because of the benefits we have seen. Kindly, Yannick, move to the next slide. Thank you. So how did we do all this? Our target counties were Kisii and Kajiado. And at the beginning, we looked at who would benefit from this training on ultrasound or obstetric ultrasound screening. And since we have seen that in every health facility, there is a nurse, UNFPA had done a study a while back, and they had seen that a midwife can actually provide up to 87% of the services that are required by a pregnant mom. And with that in mind, and also looking at the population against that of sonographers, we looked at it this way. Studies have been shown that a nurse, a midwife, can and is able to do an ultrasound. Then how do we leverage on that? Why not train some of these midwives from different facilities within the two counties that you are looking at? And let us also include a business, a sustainable business. In the beginning, you'd had Margot mentioning that Philips Foundation is not only there to support for a short duration of time, they want to see sustainable projects that go beyond their funding. And that is exactly what you are looking at with this project. So we went ahead and talked to the county governments and requested for them to give us guidance on where this ultrasound would be most effective and efficiently used, where most mothers would gain from the ultrasound screening that would be done. We were happy to get about 10 facilities, 5 in Kajiado and 5 in Kisii. And in these facilities, we did not have the ultrasound. We did not have any ultrasound machines previously there. So this was a good starting point for us. The county also went ahead and helped us to select the midwives who would support us through this project. These midwives were about 2 to 5 in each of the facilities. We call each facility a business unit, and they were supported by a sonographer. They had to first go through e-learning that was provided by Philips. And after they did their e-learning for about 2 weeks, then they were to do a physical class whereby they would engage and do a lot of practical sessions. During the month of November to December 2019, they were able to screen about 950 mothers for learning purposes. And after December 2019, we began charging mothers in January 2020. And this is whereby we wanted to see how sustainable can this model be, whereby you have a midwife who is able to provide an ultrasound screen, and she is able to buy her supplies and also gain a bit of income from the work that she was doing. And at that particular time, we had done a baseline survey that had shown that mothers, about 37 mothers had 32% of the mothers had recommended to rather pay 1,000 shillings for the ultrasound session, and the rest, who are the majority, had requested to have a payment of less than 1,000 shillings. So we went to the middle ground, and that was about 500 Kenya shillings, which is about $5, which we continued to charge between January 2020 to date. We have also seen that each of these the payments that are being done, and also how much a midwife earns and how much a business unit gains, is basically based on performance. So the more I screen mothers, the more my revenue increases, the more I'm able to buy supplies for myself, such as gel and etc. And the more mothers are coming to that particular facility. Yannick? So what kind of technology have we been using? We've been using the Lumify technology. I know when we started saying that we are going to train midwives on a mobile device, most of us were worried, what does that even mean? But as you can see, Philips have this Lumify probe that can be attached to any smart Android phone or a tablet to help as a screen. And we used a 10.1 inch Samsung tablets that would help our midwives to view as they went on to do the screening. Yannick? So this is basically the roadmap. In every project, it is advisable. You must have strong foundations, and a strong foundation will include a very strong stakeholder engagement, partnerships that will last beyond the project that you're doing. And we engaged the Society of Radiographers, we engaged the Nursing Council of Kenya, the Midwives Association of Kenya, and county governments. So at the beginning, we had this agreement that this is what we were going to do over a period of 1 year, and we would get support from all these organizations. Then we went ahead and did a TOT training of about 10 sonographers. I will point out that these 10 sonographers came from these counties, and they already were in the county, or rather they were county employees. So they were able to support our midwives through training and support supervision. We trained the 42 in the 10 facilities, and we continued to do the screening and implementation like I've mentioned to date. We have been able to train about 1,250 between January 2020 to December 2020, and these were paid ultrasounds. These were not for free. And as we have been in the talks of doing an end of project evaluation, which is currently ongoing, we are also working on the scaling up of this project. I will point out that once UNFPA heard about the work we were doing, they were able to support 2 counties, whereby they purchased 4 Lumify machines for 2 facilities per county. That was in Migori and Homa Bay. So as I had started, this work was not to end. It is work that needs to continue because of its benefits. Yannick? So this is how the business unit looks like. And the business unit here is the health facility. We have between 2 and 5 midwives per business unit who has gotten support from the government, because the government, in this case, is the county government, that they did the selection of these counties, they did the selection of the midwives to be trained, and they're always there to give authorization of anything that is required for this project to carry on. We had Philips, East Africa, providing the Lumify machines. At our end at the university, we did business training as well as ultrasound training. The business training because you want the midwives to communicate and do a sale, not only for their own benefit, but to convince more mothers to get this ultrasound for their own benefit. After we did all this, we had the sonographer training and constantly monitoring on these midwives so that they could give the right report, and they could also confirm Yannick, kindly move on to the next slide. Thank you. So what were the results after this 1 year? We are glad to report that we have screened over 2,000 ANC clients. That is those who were screened during the training as well as after the when we started the charging for the screening. We have had the uptake of pregnant women on the ultrasound increasing to about 50% from less than 10% when we were conducting our baseline. And something very interesting is that we realized that the mothers used to really travel a long distance to get to a point where they would get an ultrasound. And a good example, I keep giving this good example. If you're in Namanga town, you have to travel to Kajiado town, which is about 90 kilometers to, and Fro is another 90 kilometers. And a mother would have to make that journey to just get an ultrasound, which was also charged above 1,000 shillings. What this did was, because one of the ultrasounds was placed at the Namanga Health Center, is that mothers would just walk from their houses to the Namanga Health Center and get their ultrasound. They get their results, they pay their $5, move on, you know. And I remember one of the mothers who we had gone to visit was saying that if there is anything we can do to continue improving the service, but one thing she said was, please never get this ultrasound out of this facility because of the benefits that we have actually seen. We also saw that within the first 9 months, about 21% of the ANC mothers received the ultrasound screening within the 24 weeks of gestation as what is recommended by WHO. So what you see on the right is basically a graph of the number of mothers who are screened per month. You will notice that there is in January we started at 84 because now mothers were getting used to the paid ultrasound services. We went really high up in February after we had community sensitization. Then what happened with March is that we had COVID really hitting us, which is one of our challenges. And we had a decline in the number of mothers who came to the facilities. Well, you know that mothers were also afraid of coming to the facilities. And then we started seeing a gradual increase towards October and November. And then you see a decrease again in December when we had the effect of the nurses' strike. Then after that, we have seen a gradual increase again in this, or rather in the beginning of this year. Yannick? So what are the lessons learned? There are many, but I'll just point a few of them. And number one, we did not learn, but we already knew that the midwives are able to learn, acquire the skills of ultrasound, and actually go ahead and implement. We also have learned that mothers are willing to pay for an essential service as long as they know the benefit of that service. They can see the benefit of this service, and it will also be something that they can refer back to. Okay, so if a mother comes in and she did not know she had a twin pregnancy and an ultrasound is done, their benefit is that now I have known that I'm carrying two fetuses. What does that mean to my planning of the birth process and so forth? And that is basically what happened for us. Mothers have continued to find the benefit of this service, and they have continued to pay for it. But also, it's linked also to the community sensitization that has been done. We realized that, wow, once the chief and the village elders sit down, the community health workers are involved, they will push for these mothers to come. And we found that every time we had a community sensitization activity, we really did see that increase in the number of mothers who undertook the service. We have also seen that once we engage the sonographers, because this is not a task shifting activity, it is basically task sharing. And once we have engaged these sonographers in the training, the mentorship, once we have them being referred to these mothers when a midwife is not able to really tell what is going on with our pregnancy, we have seen that strong bond and strengthening in the health system once we have engaged these sonographers. We also found out a very interesting thing that once we set up these lumifiers within the public facilities, we had a very high number of flow of clients as opposed to those who are privately owned. And as we forge forward in our conversations with the county governments, we are working towards having more of these lumifiers and ultrasound screening gadgets being bought and owned by the county governments because of the high number of clients that will always flow in these kind of facilities. Yannick? Challenges. What is life without challenges, and what is a project without challenges?
Priscilla, you have 1 more minute, please. Thank you.
All right. So our biggest challenge was COVID-19. We also had a high dropout of midwives of about 36%, reason being that they were moving to other jobs. And I will now highlight, because of the time, I will highlight the sustainability model that you came up with. We realized that if each of the facilities would only see about or screen 20 mothers at $5, that to break even would take about 10 years. But if we do not have COVID effects, we have more engagement by the counties and community health workers, then there would be an increase or a growth of about 25% in the numbers of mothers who come for screening, which would be about 95 mothers per month. And if that was sustained over a period of about 8 years, then would have each of the facilities breaking even at year 6. Dr. Dirango, can I go to the next one? Yes, on the recommendation. Thank you, Yannick. So our biggest recommendations are that we need to empower women to understand the power and the benefits of ultrasound so that they can increase their uptake. We also have to have sustainable business models that are mostly led by our national and county governments. And we also need a policy framework that helps us define the scope of task sharing. I believe my 1 minute is up, and I'm grateful. Thank you so much.
Thank you so much, Priscilla, for that insightful presentation. You've really been able to present to us the business case of this particular ultrasound task sharing activity where, midwives are concerned. You have indeed brought to the fore the key question that is always debated among nurses and midwives in this country, and that is, how do we cost the nursing and midwifery service so that then we are able to have, this cadre actually being out there and being able to provide service and then being able to charge a fee for it. So it's been interesting listening to the Kenyan case. We've had Mimba Yangu, we've also had the project that Priscilla has just presented. I'll now shift gears a little bit, and I think we need time for about, to learn from an experience. of a project similar to the ones we have talked about right now, that has been ongoing for more than 10 years. So allow me to introduce our next speaker, that is Professor Kristen. Professor Kristen is the co-founder of Imaging World. She is actually a professor and chair of radiology at Lana College of Medicine at the University of Vermont, and is also a national and international leader in the field of radiology. Dr. Kristen has scholarly interests and accomplishments which include unique applications of ultrasound in rural medicine. Interestingly, one of the key questions that has come through is this type of model feasible in the rural areas? Dr. Kristen has experience in over the past 12 years where she has been able to be involved in work that is bringing sustainable, high quality and affordable ultrasound services in clinical facilities in rural Uganda and Malawi. Imaging World has received a number of grants, particularly from organizations such as the Bill and Melinda Gates Foundation. She sits in very many international committees and has also served as a member of the World Health Organization Referral Guidelines Development Group. Allow me to welcome Dr. Kristen. And as Dr. Kristen comes on, please continue sharing your questions on the chat, and we will answer them at the opportune time. Over to you, Professor Kristen.
Thank you, Eunice, and good morning, everyone. Thank you to Phillips Foundation for inviting me to participate this morning. I'm honored to be on a panel with such distinguished speakers. Imaging the World is a nonprofit charitable organization founded in Vermont, USA in 2008, but operates as a registered NGO in both Uganda for 12 years and Malawi for 3 years. Our original funding was from the Gates Foundation, as you've heard, but since we've partnered with others, such as Phillips Foundation, with whom we've worked for many years, Rotary Clubs, Rotary International, other civil society funders, private donors, and academic institutions for research. Next slide, please. Our program stands on 6 pillars. First, Imaging the World implements ultrasound technology at qualified rural or remote health centers. And just to be clear, we work only in the rural areas. We've been using Lumify at the point of care for several years. This then launches a 2-year partnership with Imaging the World that includes training of 2 to 3 nurses or midwives per site, supervision, infrastructure support, including supply chain for gel, network, power, and communications with local hospitals for referrals, as well as community outreach. Key is quality management with remote peer review that meets or exceeds the USA Joint Commission standards. We include sustainable business development in year 2 so that safe, high-quality programming continues after our exit. And then after that, we have free CPD courses that continue through Imaging the World that are continued in perpetuity. Next slide, please. The backbone of our model is a technology-based IT solution. While the nurse performs a basic obstetric scan at the point of care and gives a preliminary report, the same nurse also performs an ITW obstetric sweep protocol that incorporates 6 10-second sweeps over the pregnant abdomen. These sweeps are then compressed, de-identified, and securely sent through the cellular network to the intranet for remote review. And this happens in a matter of seconds. Because the sweeps capture a series of still images, all of the anatomy of the pregnancy is included, and experts can remotely review the images as a second look for peer review quality assurance or for consultation when needed for emergency care. Next slide, please. Since starting the program, we've trained over 350 nurses and midwives performing over 400,000 scans. We do have a train the trainer program, so all training occurs locally. We've observed a significant change of 25% in the pregnancy management or delivery care plan based on the scan findings alone, with referral to a higher level of care when necessary. And this really underscores the importance of antenatal scanning. We also see a 70% increase in utilization of the facilities for ANCs and skilled deliveries. There's a clinical magnet effect, as you see here, as women who come for ANCs get additional testing and treatment for comorbidities of pregnancy like malaria, worms, anemia, HIV, and hypertension. Private facilities are sustained through a small affordable fee for the scan, while public facilities are sustained through budgetary practices at the DHO level. An expert team at the Imaging the World Africa offices in Kampala, Uganda, and Blantyre, Malawi create a stable infrastructure and locally oversee all of the activities, including the exit strategy as clinic sites are launched into independent practice at 2 years. Next slide, please. For the future, we plan to cultivate partnerships, new and old, as we have with Phillips Foundation. We're in the process of building a Center for Health Education Research and Innovation in Kampala, Uganda, that will immediately serve as a centralized center for ultrasound training. Our recent grant award from African Academy of Sciences, Grand Challenges Africa, allows us to further expand to areas of greatest need, including to refugee settlements in northern Uganda through an agreement with the Prime Minister's office, and soon partnerships with other entities such as UNHCR. Our main research targets are in cost effectiveness and community acceptance and uptake of point-of-care diagnostics, as well as looking at how artificial intelligence can improve our efficiency, access, and overall care. We hope to extend services for new clinical uses, both in ultrasound alone and in combined diagnostic practices that are essential for care delivery. In summary, we have a scalable turnkey solution that optimizes integrated health service delivery for communities in remote resource-constrained areas. Thank you.
Thank you so much, Professor Kirsten, for that amazing presentation, brief and straight to the point. You have indeed started to address some of the questions that are coming through around, is this type of model actually implementable in rural settings? You have indeed shown from your 10 years of running this project that indeed there is an element of increased antenatal utilization, when you do this ultrasound model, but also the fact that you have a good sustainability plan in place and the use of TOTs to ensure that actually you have locally available individuals who can continue to train others. You've also, in your presentation, highlighted that there is actually some element of positive outcomes because of the opportunity to identify abnormalities and refer them accordingly. Thank you so much for that presentation. We'll now shift gears a little bit and look at, the role of training and the role of involvement in increasing other cadres who can be used in task shifting on particularly increasing access to services for pregnant and for pregnant women. To take us through this is Dr. Alina Durrani. She is a regional lead for corporate health and wellness at DoctHers. Dr. Alina is currently an incoming candidate for a master's degree in public health. And she also had, for a master's in public health and health policy management at Columbia University. She holds a bachelor's degree with honors in medicine and surgery. She has experiences in early childhood development, affiliated with the education sector in the UAE, hospital administration, across private and public healthcare sectors in Pakistan. She is dedicated to help improve healthcare delivery system in Pakistan with a keen focus on maternal and child health and special interest in the field of global health and policy. Dr. Alina, you're welcome to the floor. As Dr. Alina takes on the floor, please keep your questions coming. Thank you. Over to you.
Good morning, and thank you so much, Eunice, for that kind introduction. I'm thrilled to be a part of this esteemed panel today and to represent my organization, DoctHers, which is a female-focused organization that uses digital technology to match the underutilized capacity of licensed female doctors to the unmet needs of health seekers. Our focus is to enable access to primary care across low-resource communities in Pakistan, and we're doing this by integrating and exploring the usability and viability of Lumify across the socioeconomic spectrum, traversing multiple provinces. So in our model, you will see 4 significant features. Number 1, a remotely located OBGYN, radiologist, or GP who is directly connected to a GP or nurse or frontline health worker at point of care. Number two, the female frontline health worker, who in our case is commonly known as the Goody Baji, who plays a very important function of being a trusted intermediary with the low trust communities. And number three, there is a digital health platform that connects the remotely located specialists to the female frontline health workers who are working in villages in low resource communities across the country. And the four most important, the female end beneficiary, the woman who is the recipient of the ultrasound service and other primary health care services. What we have done is that through this model, we have shifted tasks to the front line that would have otherwise happened in hospitals. Those tasks are being shared by frontline health workers who are digitally connected to either remotely located or hospital-based specialists. So there's both task sharing and task shifting. So how do you make healthcare systems more affordable and more accessible is by shifting to the front line, to the front lines, to where the patients actually live and where they work, and basically take the access to their doorstep and take the burden away from tertiary care and sort of lessen or share the burden. One of the biggest challenges in Pakistan has been the tertiary care system serves as primary, secondary care, and that's why the system's always been overwhelmed. So this model is not just more cost effective, but also more culturally sensitive to the needs and constraints of women in these communities who we're serving, depending on the geographical locations where they're located. So I want to share with you two case studies that we've done here to evaluate what I now call the Lumify magic, which will give you a sense of contrast that we are confronted with when we deliver these kind of services. So one is an urban slum model and one is a rural mountain village model. So if you look at my first case study is in a rural mountain village in the outskirts of Madan in northern Pakistan, and meet my patient Farah, who learned that there was a cord around her baby's neck and was immediately referred to advanced care management. Here you can also see our digitally upscaled, cheerful Goody Baji Mariam. Here you have poor video connectivity but satisfactory audio connectivity, so you can do audio calls, and the role of the GP becomes absolutely essential, because in this case scenario, we wouldn't have been able to conduct the scanning without a GP, or the patient outcome would not have been the same either, because I was essentially translating, improvising, and doing most of the work guided by the radiologist on an audio call, and we had to resort to that since there was absent 4G connectivity in the area. That's not what I feel a lady health worker could have possibly done in this case scenario, but the utility of being able to have access to a GP is absolutely vital. This gave us insight into which model may or may not require a GP at point of care. Now it's conceivable that nurse and midwives should be able to replicate the same, but most nurses and midwives are only present in urban centers. Right now, the Goody Bajis or paramedics that are working with us in deep rural areas, we don't believe that they're at the level where they can independently do this on their own, but if they're properly trained and qualified, then we believe it can be done. So the question is, what does that training look like? Is it practical? Because training has to be feasible, practical, effective in order for frontline workers to be able to do what they need to do in these geographies. And because it's not practical to send out a team every couple of months, so most of that training needs to be done online, and that is something that we're potentially looking to do with the Aga Khan University School of Nursing and Midwifery to get training for our Goody Bajis in midwifery. If you look at my second case study, it's in a peri-urban slum area or settlement area called Orangi Town in Karachi, which is the 5th largest slum area in the world. And you see my patient Sarah here, who saw her baby's heart beating healthily after 4 miscarriages. Again, Lumify magic. And in this particular case, the connectivity was reasonably good. We were able to successfully connect a remotely located radiologist and OBGYN. And over here, also a radiologist accompanied us to conduct the antenatal ultrasound screening. And we learned that where the connectivity is good, video diagnostic imaging and video conference calls tend to be doable, even if the scanning is conducted by a lady health worker. So it was a perfectly workable, feasible scenario. The good thing about urban slums is that the connectivity tends to be good. So because they're densely populated, there's more patient footfall. These locations are easier to implement this model in. Higher numbers, higher concentrated volumes, better connectivity, better physical access to healthcare providers if they want to physically visit. So in these settlements, there is poor access to care. However, it's more practical to send qualified nurses, midwives, as a frontline health worker who then connects to a remotely located OBGYN or a radiologist. The technological feasibility of the device is that it does have clear images and fantastic loops, and it has excellent clarity and can be used as an effective tool for antenatal ultrasound in the right setting. The question for us is that what is the right setting currently in Pakistan? And based on my observations, I learned that where there is good connectivity, as I mentioned earlier, which is usually going to be in large peri-urban slum areas, is kind of the recommendation which should be the point of focus for us. There's definitely a practical role for this device in that kind of setting, given that there is also increased affordability in these areas, as we observed. It's densely populated, it's much more practical, it's easier to deploy lady health workers logistically. So making a contrast between what is feasible today, the device is viable and it can create value in that kind of setting. In the other case, in the mountain villages, the connectivity was very patchy, it was poor and mostly absent. And therefore, I obviously had to improvise and sort of be on an audio call and carry out the scanning myself. Other than that, there were other cultural challenges that we perceived or foresaw. For example, things like gender disclosure in both venues, which is a controversial issue in Pakistan, and we really have to look out for the safety of our personnel. Conclusively, the prerogative is to give Lumify device in the hands of either nurse midwives or goody bajis or both, depending on what we find out with research in terms of who this device can be used by, and then deploy Lumify in urban slums to begin with to begin with, because that's where we feel it's more likely to become sustainable. Rural areas, for all the aforementioned reasons, are still too problematic right now, at least the ones that are far off in the mountainous terrain and last mile villages, as we continue to test and create an economically viable model to collaborate with multiple sectors for scalability. Thank you.
Thank you so much for that presentation, Dr. Alina. You have indeed been able to show us how shifting care to the primary level and to the community just makes care a little bit more affordable, but also accessible. You've also really shown how you use technology, both audio and like over voice or over video, to actually get connections with a specialist who's located in a different location, which then means that the person who's providing point of care ultrasound is well supported as well. It was interesting listening to some of the cultural issues that exist around gender disclosure, and I guess that's addresses some of the issues that have been coming up around what are some of the contextual issues that are important for us to think about. So our participants, thank you so much for listening to the 4 presenters who have gone before us, who are our keynote speakers. We will change strategy a little bit and go to a panel discussion. So our 4 key speakers are going to be joined by 4 other individuals. Please allow me to briefly introduce them. The first is Dr. Bashir Isaac, who I will ask to put on his video as well and be on standby. Dr. Bashir is the head of Department of Family Health at the Kenya Ministry of Health, where he oversees the divisions of reproductive health, maternal health, child and neonatal health, nutrition, dietetics, adolescent and school health. He was the immediate former program coordinator for UNFPA Kenya, leading a joint program of UNH6 partners to end preventable maternal and child death in the 15 countries with the highest burden of maternal mortality in Kenya. He was also the senior advisor for the group formerly known as Future Groups. Allow me to welcome Dr. Bashir to our panel. Our second panelist is Angela Siteye, who is from Farm Access and Director of Innovations Kenya. She started her career as a licensed nurse. She went on to graduate in healthcare management and the Bachelor of Science degree, and holds a master's degree in health systems management. Currently, Angela is in charge of health innovations portfolio at Farm Access. Welcome, Angela. Our next panelist is Dr. Matthias, who's the Philips Business Category Leader Access. Dr. Matthias has been in Philips since 2012, where he has held various positions in the Netherlands, China, Belgium, and United States. Before leading Access and OB Business based in Shanghai, he led the Tomtech and Ultrasound Solutions and Informatics segment. He comes to us with a vast experience in business management. He has also been a management consultant in high-tech and healthcare industry. He has a master's degree in science and a PhD in mechanical engineering from University of Technology in Delft, and an MBA from University of Rotterdam in the Netherlands. Those are our three additional panelists who will be joined by Maho, who spoke earlier and introduced us. She is a lawyer, and after being a company lawyer for 3 years, Maho has then moved on to set up her businesses and led companies to growth before joining Philips. She was an entrepreneur for 23 years. As you can see, we have a really good panel with us today. And to start us off, since we have had quite a bit about, the implementation side when it comes to the research around use of ultrasound for maternal screening, I'd like to start with Dr. Bashir to sort of give us his reflections from a policy perspective coming from the Ministry of Health. How do you see this fits into the policy in terms of where your department lies? And perhaps seeing how this then informs the next steps, based on the evidence that we have seen from this project. Dr. Bashir, over to you.
Thank you, Eunice, for that opportunity. I have listened well, and I must admit this could be my first time to interact with this data. We've always believed that we give our clients the highest standard of care, including reproductive and maternal health care. And as a country, we have prioritized maternal and newborn care, and that's why it's a presidential and First Lady's agenda. The issue of now task shifting ultrasound to the nurse midwives is a welcome agenda. It's the only, what is left is for us, we know it works from the evidence that you've been sharing here. And the only thing that I wanted to know is that, is there any statistics that points to the fact that these maternal ultrasounds actually reduce maternal mortalities? Any written paper that we can use? The cost of these ultrasounds, I know, are things that we can discuss at different levels. In short, there is a future hope, and it's sellable in the country, especially the model of the business sustainability, where maybe the government is not expected to put in a heavy investment in the training and in the equipment. It will be very easy for us to sell that concept where you don't require a budget from the government. I'm sure most of these government facilities have ultrasounds. Maybe about 4,000, 5,000 of them may be having ultrasounds. It's just another 3,000, which may not be or having. And if these gadgets are cheap and we can have the Spirit Foundations or any other donor to support the initial investments, we can also look at these trainings to be imbibed and the curriculum to be sold or done at the pre-service institutions where we churn out these nurses and these midwives. I chair the pre-service steering committee, where we're dealing with the midwives and nurses that deal with maternal health and child health. And it could be an opportunity for us to present there. I'm not sure whether the Aga project was presented in that forum. And I'm happy that you have involved, especially the AMREF project, the Society of Radiologists of Kenya, and the NAC. Usually what we have is inter-cadre jealousy and war, that if you are doing a task shifting, you're taking away some work from some particular cadre. But having blessings from the Radiology Society of Kenya is a good move. And it will be easier for us at ministry level to have this as a policy and maybe make some recommendations together with the Nursing Council. We can work on a framework and a guideline that can help us develop, first of all, an advocacy package on these societies and stakeholders, and then sell it to the ministry as something viable, and that's something not very costly. And we have the trainings in the pre-service institutions. That is my take. And the only thing that I wanted to tie the knot on is what is the cost of these devices for the public sector that don't have for us to budget? And then how long is this training that you have been doing? The fact that you can also do this training online is a welcome. And we've learned a lot from the COVID pandemic that many things can happen online, but we should also have some mentorship and at least physical interactions with the nurses. We have a huge number of nurses who are already in the field, and to catch the ones who are in training now is where we can actually have a more sustainable effect on the training component of it. Over to you, Eunice.
Thank you so much, Dr. Bashir. I think you've really provided some good insights around the need for, inter-cadre collaboration, and really looking at this not as an issue of task shifting, but task sharing, in order to have an approach that is interprofessional in nature. Indeed, issues of maternal child health are not a one-cadre issue, and the underscoring message here is that interprofessional education becomes critical. The idea of ensuring that at least we have this included in the pre-service is an interesting one which the panelists involved in the various projects need to explore around engagement with the regulators to see how then that becomes entrenched in the curriculums that are being developed and offered. I'll now move to Angela. Angela, from your experience from farm access, in terms of point of care ultrasound, what would you want to share with us from that experience, especially, mothers' willingness to pay, how much this costs, in terms of the project you are doing, going back to what Dr. Bashir brought up, and the use of e-wallet savings in that project. You could also, tell us how, are there potentials for having like a medical credit fund, in terms of providing credit when it comes to purchase of equipment that are needed in order to be able, to run this particular type of project. Over to you, Angela.
Thank you very much for the opportunity to share in this webinar. And I think slightly different from AMREF, we did almost a similar project, but a smaller one. And also as we focused on healthcare providers, really private healthcare providers. As farm access, what we do is we look at innovative solutions to strengthen gaps in the existing system, where the collaboration with Philips through Lumify, as well as healthcare providers who had our other models already, such as the safe care model, which is a quality model really, where as a patient, by the time I go to the hospital, I get safe care basically, because we support the healthcare providers in terms of putting in structures in place for high standards of quality. We also had the medical credit fund, like you mentioned, where we actually offer financing for healthcare to improve quality in healthcare. So basically, whether it's equipment, it is working capital, it is infrastructure, and the likes. But Philips then came in, and then we also had the wallets, which is, for some of you have heard about MTBA. MTBA is actually a platform that connects the patients, the payers, and the providers. And so MTBA also came to play within this, which is also an innovation, of farm access that was tested within farm access and scaled, and now has its own life under one of our sister companies called CarePay. And so we piloted within 2 facilities really, in Mombasa and in Nyandarua. But one of our providers within the private facility.
Sorry, Angela. Angela,
Yes.
Can I ask you to put your mic a little bit closer so that your sound is a lot more clearer? Thank you very much.
Can you hear me now clearly?
It's a lot better. A bit of echo,
Okay.
but please proceed. Thank you.
Okay. So we piloted.
I've lost Angela, so allow me to put her on hold as our technical team follows on that. And I'll now go to Dr. Matthias. Let's shift gears a little bit in terms of looking at this from a business perspective. And I wonder, what do you see are the key points pain points in terms of barriers and tensions around implementations of solutions such as this one? And perhaps drawing from your own experience, where do you see as potential solution in terms of addressing those barriers and tensions that you might see on this?
Yeah, thank you. And first and foremost, thanks to all the speakers. It's really great to get it all together. And Dr. Alina, I'm going to steal your catchphrase, the Lumify magic, which makes me incredibly proud. I love that phrase. And it's what it does. I think, everybody here on the call would recognize a lot of the hurdles that have been brought forward. I think talking about, the lack of skilled sonographers, and then the affordability apart from the physical access. And I think in order to overcome that barrier, from my perspective, I think there's also a role for technology here, because what we haven't addressed in this webinar so far, I think, is the role that, for example, artificial intelligence can play on the device to not only let's say, make it easier for sonographers to adopt ultrasound in antenatal care and get more confidence in the diagnosis that they do, but also to speed up the exams. Because if we really want to be successful, I also think that we need to think about scale and volume. So apart from, I think, what we can do in terms of technology and making it more accessible, gaining more confidence, it's also about how can we get more volume to it? Because the key to make it affordable for me is also to get to a huge install base and get the cost per scan really down to not $5, as I heard, but why not to $3 or to $2 or to $1? And the way to push that down is really in terms of scale. And the other piece, I think, where a technology provider as Philips can add value is also to provide the whole infrastructure associated with this. So I think, Dr. Alina, you already referred to connectivity, right? And of course, we can put part of the intelligence on the device, but it's also about the infrastructure. How do we connect the frontline workers to the higher level hospitals to provide care where it's really needed and be really selective in who we refer? And Dr. Bashir, to your question around, what is the price of a Lumify or of an ultrasound? That should not even be a relevant question for me. It's about getting the ultrasound out there. We'll make it work, provided that we can get to that scale. And if we can get to that scale, I think that the initial investment from a technology perspective should not be the case. Then we really can go to dollars to the exam and really make it accessible. And so I think a lot of the hurdles that I heard to get access improved, but also to make it sustainable, can be resolved. And it's exciting to see all those examples. And I get itchy just to get cracking at it. Back to you.
Thank you so much for that, Dr. Matthias. It's interesting how you've talked about the issue of artificial intelligence and the need to actually think about the economies of scale. So how then do we expand this, a little bit further? And, leading to that, I'm going to ask Maho, how do you see the solutions that have been presented here, for the Philips Foundation pilot project? How do you see this being scaled up so that then we're able not only to bring the cost down, but also to start to utilize some of the elements that we've seen here around increasing accessibility and use of other elements around bringing the cost down? Dr. Maho? Maho, can you hear me?
Sorry. This is really what it's all about. And hearing the insights of all the pilots we helped set up exactly because we want to learn what will make scaling possible and what elements do work and which do not work. And maybe even the combined elements of what we heard today, of the different and very various examples, lead to so much information that helps to standardize an approach that is scalable, because that's what we think is necessary to really understand what works, to standardize it, to make it as efficient as possible, as also Matthijs is mentioning, to get the cost down, which makes it affordable, and that's a major part of accessibility. Philips Foundation is all about providing access to quality healthcare for disadvantaged, for underserved communities. You are all working on those cases, and collaboration is key, affordability is key, and standardization is key. And that would be the next steps that we want to be working on. What is the best way to scale? That is collaboration, and that is finding a way that makes it possible to really accelerate scale. Philips Foundation is, if we talk about budget, of course, a small player. However, I think the capabilities we have brought together, and the insights and the support of Philips as a company that really wants to learn these insights and really wants to provide access to care at scale as well. I think we have gold in our hands if we look at what we heard today. And Dr. Bashir, I'm really happy, and we know you also from other projects, of course, as a very proactive representative. Very happy to hear you ask about the pricing, and your intention to really bring this at scale. And let's see how we can work together. We need the governments, of course, as well. Regulations are key, facilitating these kind of approaches. And this task sharing is essential to make this kind of healthcare and antenatal scanning and insights available to all of those people. So we are completely open to the next steps. Let's collaborate. Let's bring together what works, and make it affordable and accelerate.
Thank you so much, Maho, for that response. It's interesting to see that the regulator has been mentioned, and I wear another hat where I'm the chair of the Nursing Council of Kenya. So most certainly conversations around how do we regulate the additional skill sets that are needed in order to be able to provide quality point of care is critical, because we have to ensure that is regulated as well as standardized, as in view of maintaining the quality that is needed. So to do all this, we do actually need to think about the training, and I think the majority of the speakers, keynote speakers, spoke about training. So to Kristen and perhaps Marlene, how did you organize your trainings? What are the short-term and long-term plans around the trainings that you needed to do for your projects?
Thank you. Who do you want to talk first?
Dr. Marlene, Professor Marlene, you will go first, and then Kirsten will go next. Thank you.
Thank you so much. So number one, maybe I can react to some of the points that Dr. Bashir was also making about the pre-service training. I think it's key. And I know the Ministry of Health is in the process of developing a training curriculum. So and I think the experience that we have built up in Kilifi can also, of course, will be shared and can maybe also be used. But the goal finally, I mean, it would be unthinkable to have to go to each and every county, sub-county facilities and to keep on training. You can do that in a pilot project. But if you really want the task sharing to be done, there will be need for a lot of discussions at a higher level. Are we going to introduce some of this training at the pre-service level? How are we going to do it? What kind of curriculum? So maybe it's a very good moment to start thinking about it. What we have done is together with the Department of Radiology, and we have involved also Ministry of Health to kind of develop the training curriculum. The problem is, as I said in the beginning, you can't train. The problem is kind of the maintenance of the skills, and how are you going to ensure quality, because these people, the nurses who have been trained, they are out there. So of course there is a system that there is a radiographer or a radiologist or a gynecologist who can do the feedback and the quality control, but how are you going to maintain this really good quality of training? So that's something that we have to work together. And maybe just 1 minute to answer Dr. Bashir's question, is there any evidence that routine obstetrical ultrasound is reducing maternal mortality? No, absolutely not. I think that the gain is really what we are trying to make is rather in this part of the world, we are the number one application, I think, or the number one project goal that we are trying to address is the big problem of the unknown last menstrual period, the unknown gestation. So a lot of research has been done, and we have evidence that more than 1/3 to half and more of the women don't know their last period, or it's not reliable. So then when a woman goes in labor and she is maybe 24 weeks or maybe 28 or whatever, it makes a big difference in management of that particular woman. So if we could have the ultrasound with number one, all women having access to ultrasound so that we have a good gestational age, I think that would be really a major step forward. And then, of course, there are the other things like the twins and the location of the placenta, congenital abnormalities. But that needs to be discussed. Thank you.
Thank you very much, Marlene, for that. Christine, I want to combine your views of that with a question around seeing the model that has really worked for you in Uganda. What are some of the priorities you feel Kenya would need to put in place if they were to make the system work for us?
Wow, that's a big question. Just quickly, I'll comment on the education program. We do 4 weeks of didactic training in 2-week blocks, and that's important because not all nurses and midwives can leave their facilities to come for long periods of time. So we take them one at a time, and we do the teaching in groups. And this is followed by an observership at the local hospital, and that's prearranged. And it's also very important to have that observership because one, the nurses get to know the people to whom they'll be referring the patients in cases of complexity or emergency, and they get to see a lot of case positives. So as you probably know, as you scan a lot of mothers that come in as volunteers, most of those are normal. And when they do an observership at the local hospital, they get to see a lot of the case positives that they'll see in their practice, including a high rate of twinning that we see in Uganda, breech and transverse presentations, placental abnormalities, fetal demise, ectopic pregnancy, all of those things. So it's really, really important to have that part of the training as part of it. What could Kenya do? I would say I don't know all of the barriers in the country of Kenya. I will say that when we first started our program in Uganda 12 years ago, nurses and midwives were not allowed to perform ultrasound at a health center 3 level. So we had to get special permission from the Ministry of Health to do that, and even through the PS to be able to do that. This then led to some really quick communication and dissemination of our outcomes. And I can't stress enough how important it is to communicate your outcomes to the Ministry of Health and to the policymakers, because over the years, what happened is that the policymakers were able to see the importance of prenatal ultrasound and incorporated it into their health service strategic plan. So now if you look at the HSSP for Uganda and Malawi both, you will find that ultrasound is listed as a test that should be provided at a health center 3 level. So that's extremely important. And I don't know where Kenya sits on that platform right now. And I would say, you know, continuing that communication and continuing dissemination of outcomes is extremely important. In our particular model, we send images over the internet. So that was a whole additional layer of permissions that were required. So as you can imagine, you know, we have developed a situation where we have de-identified data that's transmitted, and we use specific numbers as medical record numbers that identify the patient with her information only at the health center level. Again, sending medical information over the internet requires permission in Uganda and Malawi, at least, from the Ministry of Health, and in Uganda in particular from the President's office himself. So it's not just a simple process to get this done. And of course, data use agreements are really important right now. So you have to be considering that. You know, so many things to keep in mind as you move forward. But happy to answer questions for anyone.
Thank you so much. That's really very helpful around, you know, some of the issues that, you know, Kenya may need to look out for based on some of the initial challenges you had when setting up. The last question for the panel discussion goes to Angela. Angela, could you share with us your experience around investment in startups and how then, you know, this becomes an avenue that various practitioners can use to be able to invest in this particular model? Please do share your experience with us and learnings from that. Thank you.
Yes, so thank you very much, and my apologies, my video and audio have not been stable. I hope you can hear me now.
Yes, loud and clear.
So within Farm Access, and as we implemented this project, we have a financing model known as one of our departments called Medical Credit Fund, where we actually do give digital loans as well as the mainstream loans. And so this can be actually an avenue that that is currently we also we currently do give these loans, and have actually given to a tune of 7 billion Kenya shillings to healthcare providers to either buy equipment, improve in quality and infrastructure. So this actually is an avenue that we can use and have used. I've actually issued before some of the loans to some of the providers that we work with to provide some of the Philips equipment, and certainly this is an avenue for sustainability as well. Part of the learnings in our implementation is that we learned that perhaps important to note is that we did work with private providers, and we realized that 95% really of these women who came for the scanning were coming for the first time, where 85% actually were on the second and third trimester. Mothers were very happy to see the baby, but initially we realized that one of the barriers is that education, like mentioned, is a main barrier. And if they were educated on this, and then we break the barrier of affordability, again, we also found out that a cost of between $5 and $8 would be something that is feasible. And then also create availability of this equipment, whether it's to the counties or to the sonographers of midwives when it is fully approved, can actually be sustainable. And as Farm Access, we are available to give those financing mechanisms.
Thank you very much, Angela, for your response. You were loud and clear. I'll now ask all presenters to please put their cameras on. We are going to now focus on the questions that have been asked by our participants. I will direct the questions to various members, both from the panelists who joined us in the last session and our keynote speakers who started us off earlier. So one of the key questions that keeps coming up is around, resources. But there's one that came around how in terms of resources that are available for e-facilities. And I think Dr. Angela gave an example of that in her presentation. So Marlene, for your project, what are some of the resources that are available for e-facilities for both access in terms of support as well as training?
Thanks, Eunice. So what we had available support, the Lumifies were provided by Philips, and the support to do the research project by the foundation. Then Aga Khan University provided the training, the manuals that were already existing and were updated, and then also the staff to do the training. So the radiologists, gynecologists were involved in training. The nurses initially were supposed to come to Nairobi, and that was budgeted for. But then with COVID and with the development of the e-learning center that was available, we took that route, and that really worked very, very well. As I said, to really scale it up from where we are now and making sure that, of course, it requires collaboration with the Ministry of Health, with the county governments. I mean, county government has been very important in this project. Kilifi County, the Department of Health supported the project. They allowed the nurses to come, so they also provided some support. And Mariakani Hospital provided the training, the hands-on training. So we are very happy to have been able to work with them. But of course, to scale that up, there is a lot more required. And what we also need to see is kind of developing good models for routine. I'm not talking about ultrasound in the maternity and for emergencies and for bleeding. But today we are talking about, in this project of Mimba Yangu, about how often every woman, according to WHO, one ultrasound scan, right? So what does it require to do that? It's not only the machines, even if you lower the cost of that, but there is a whole task force of nurses, because if now in a level 3 facility the nurses are available, if those nurses are trained and they are now the ones expected to do the scanning, how much time will it take? How much, because this is Ministry of Health staff, right? So what is the task force required to provide that one single scan? That still has to be, so we are working with a group of health economists also to look at the feasibility and the cost and the affordability of the whole program, not only the machines, but the training, and then who is going to do the work. Thanks.
Thank you so much, Professor Marlene, for that response. The next question, I'll address it to Priscilla, and this question came during your presentation and Marlene's presentation. What is the role of men? What is the role of men in creating awareness of this? Because we all spoke about, talking to the women and encouraging them. So what is the role of men in raising their awareness and in engaging them in the ultrasound and ANC visits? Priscilla?
Thank you. So in our culture, men lead. Men are the budget holders of a family. And men do decide for women on what health services they should acquire. But our biggest role in bringing them on board with us is ensuring that they understand the benefit of the ultrasound being offered to their wives. Anytime you place value to a service, that is it. And how do we do this? We ensure that anytime the mother comes, we encourage her to come with her spouse when he is available, or they create time to come with them. You have time to explain to them how the ultrasound will be done, but above all, what is the benefit? It is one that we may find that this pregnancy has a complication. What does that mean? This helps us to refer your wife or your partner in good time to the next level of health level. Then from that, we are able to save her life and that of the fetus. You see, once you tell me that, and I look at $5 to the health of my wife and my child, the man will actually pay 500 shillings or the $5 because life is much more valuable to the money that we have. So it is for us to make that difference, to communicate the benefit and ensuring that people buy in into this vision that you have, because you also want to see this mother going back home and having a successful family after that. Thank you.
Thank you so much, Priscilla. The next question I'll direct to Dr. Kristen. There is a question around the use of the ultrasound in labor wards, for instance, during emergencies when mothers get to be referred from elsewhere. And you can perhaps link that with the question around what information does a basic ultrasound provide?
Sure. So it's different in a labor ward. When we do our training, we also do a refresher course at the maternity wards at the referral hospitals where the nurses will be referring. So we do have Lumifies also at the referral hospitals that are used on the labor ward. Basic ultrasound scan helps to determine a few things. One, fetal viability, meaning is it alive or not? Two, is it intrauterine, inside the uterus? 3, how many are there? 4, where is the placenta? 5, what is the presentation? Is it first? Is it transverse lie? And what is the amniotic fluid volume like? Because that can be one of the signs of distress for the mother when the volume is low, especially when it's not near term. And we do dating as well. So this is a basic scan, includes all of those things. We don't have the midwives and nurses learn to do, for example, fetal anatomic surveys in the second trimester. They're really just doing a basic scan to identify complications of pregnancy that would require a higher level of care and referral.
Thank you very much, Professor Kristen. The next questions I direct them to Dr. Marlene. Marlene, in your project, did you have cases where you had abnormal ultrasounds? And what type of support did you give in terms of referral? And this question actually comes from a background of concerns around affordability in terms of transport, distances to the next facility. So in your project, were you able to deal with it? And I'd link that to what outcomes have you seen so far when you use the ultrasound and the mom?
Thank you. So as I said in my introduction, we have just finished our training and our refresher training. During the training, we have done a number of scans, of course, but we did them at Mariakani Hospital. So when there was a problem, Dr. Vanjala, who was one of our trainers, but at the same time working in the hospital, the referral was quite easy. Of course, we have discussed now that the 17 clinics are going to start and they are in remote. How are we going to do the referral? There will be some support for women to be referred because this is a kind of implementation research project. But when you plan the scale up and really having it in ultrasound as a routine in all pregnant women, there will be within the ministry, within the public health sector, a system will have to be set up. Like, how do you take the woman with or maybe suspected abnormality, or you want to send her to a higher level? It will come in the same referral system than when we have a high blood pressure and we have to refer a woman for care from a level 2 to 3 or higher. But this is something to be addressed, of course, and it is addressed in the training. If I may just to add one thing about the role of the man and about gender, what was also said, I think it's so important that the community is involved in education and learning and awareness of what actually is this ultrasound scanning. Because we had one case where a husband was very upset because somebody had told during the scan that it was a girl, and they had already 2 girls in the family, and he was very upset with the wife. So the rule is, at least for us in our training program, not to communicate the sex of the baby. But it's not only that. That's an obvious example. I think we have to learn how to communicate. For example, we teach our trainees not to say that everything is okay, but that during the exam with ultrasound, we have not detected anything abnormal, which is different. If you say everything is okay and then a baby is born with something that is not okay, then the community starts doubting what you are doing, because some things you should see them on a screening, but not everything. So that concept of it's not like you take a Polaroid picture of a newborn. It is a different communication, and that has to be very well realized. Thank you.
Thank you so much, Marlene. Participants, we have so many questions coming in, and in the interest of time, we may not be able to address all of them. However, we have tried as much as possible to include some of the responses on the chat. Allow me to end, obviously, on a note where I pose the next question to Dr. Bashir. Dr. Bashir, there's been a number of questions around affordability of this service. The last person actually did ask on this asked, can we utilize the existing National Health Insurance Fund to actually pay for the ultrasound? Over to you, Dr. Bashir. What are your thoughts on that?
I am not the authority for NHIF, but we have Linda Mama project, which covers all the mothers for their maternity services. And it's just a matter of us sitting down and including this into the package of the Linda Mama. That could be an avenue for us. But there are a lot of other steps of advocacy, policy change, discussions with the stakeholders before we come to that kind of a decision. Thank you.
Thank you so much for those comments, Dr. Bashir. Allow me to first thank all the panelists for spending their time and sharing their knowledge, their experiences, and engaging in the presentation. At this point, we'll go to the closing section. And I'll have failed if I don't thank the participants who've taken so much of their time to listen to us today, to share their questions and to share their views. And we really are very keen on having you all. I would like to ask that as we are closing, that all our panelists and presenters, please to keep your cameras on so that at least our participants know who was engaged with them today. To bring to the close, I think a lot of issues have been discussed today. A lot of also call to actions, indeed, of matters that need to be followed up have come up. One obvious one has been around the regulatory landscape, both from the regulators and the ministries of health, engaging the various bodies, as Dr. Bashir has said, for instance, the conversation around NHIF and funding of this, and things around, of course, how do we include this in the pre-service training? How do we streamline the task shifting so that we have all cadres that are involved at the fore? We do know from the presentations today and experience shared elsewhere that this does work in terms of ability to have ultrasounds done and have good quality reading, as well as ensuring that indeed, we are able to use this as something that is streamlined in the healthcare provision that is provided. We also saw a lot of discussions around the business model. How do we fund it? How do we sustain it beyond that? How do we then ensure that nurses and midwives are able to cost for this service? And of course, I did enjoy listening to Matthias talk about the ability for scalability so that then we are able to bring the costs down. So thank you so much, everybody. I will now hand over to Mahal to do some closing comments. Thank you.
Thank you, Eunice. I want to start with thanking you for your professional moderation of this rich session. Thank you very much. I think this is not the last time we meet, and that goes for a lot of panelists and participants in this meeting. This is only the start, I would say. We are succeeding together in finding ways to provide antenatal scans and information to the people that need it most, or the people that are lacking these services. Next steps would be to understand and to discuss what we can do to accelerate scale. That we will do with the people in this meeting. And yeah, I want to thank all the participants for their attention and their questions and their involvement in this meeting. Thanks for your interest, and hope to see you again soon.
Thank you, Mahal. Thank you to the Philips Foundation for this. We look forward to the subsequent webinars. And with those few remarks, thanks everybody. And I'll ask the panelists to please wave and say thank you to everybody for their participation. To all our participants, have a good day. All the best. Thank you.